The combination of bendamustine and rituximab, BR, is commonly used in the relapsed setting, and because we saw so excellent results with ibrutinib as a single agent in phase 1, phase 2 trials, we wanted to combine that so that we have not only chemotherapy and an antibody, but also the novel drug. So we have 3 therapeutic principles combined in one treatment regimen. And this trial was a double-blind, placebo-controlled phase 3 trial, which was run internationally in 21 countries. The trial included 578 patients, so it's a huge trial. 80% of the patients had a unmutated IGVH status, and 30% had a deletion 11q, which is also associated with adverse prognosis. However, patients with a deletion 17p were excluded from trial participation. The median number of previous therapies was 2, but a significant proportion of patients had already received more than 3 therapies, and also half of the patients had bulky disease. So that's a proportion of patients which are sometimes not so easily to manage. These patients were then randomized to receive BR 6 cycles with either placebo or ibrutinib. And the primary endpoint of the trial was the progression-free survival, and this was shown to be much better with the addition of ibrutinib. So the interim analysis, which was recently performed, showed that the median progression-free survival was 13 months with BR, and with the addition of ibrutinib, this wasn't reached. And the curves are separate very hugely, and there's a highly statistically significant difference between these 2 curves. So we can say that the addition of ibrutinib leads to 80% reduction of the risk of progression or death. Regarding the secondary endpoints, we can say that the overall response rate was also higher with the addition of ibrutinib. That was 83% versus 68%. And also the CR rate and MRD negativity rate was higher if ibrutinib was added. Regarding safety, we didn't see anything new. Actually, the safety profile was just as expected for either the combination of BR or ibrutinib. So if we add that together, this is what we see in the BR plus ibrutinib arm. The hematological toxicity and infections were pretty much the same between the 2 arms. And in addition, with ibrutinib, we saw some more rash or diarrhea, which is known with ibrutinib, which were mainly low-grade adverse events, and also, but very rare, bleeding events and also atrial fibrillation. The overall survival was also an endpoint of the trial. However, since the median observation time is only 17 months, there's no statistically significant difference. However, we see some trend between the curves and hope that this might turn out positive after a longer follow-up time. But seeing these curves, we have to bear in mind that a lot of patients crossed over from the BR placebo arm to receive ibrutinib monotherapy once they progressed. So the result is confounded by this crossover. It has definitely changed the whole landscape of the treatment of CLL, these novel agents, and especially ibrutinib. It's now licensed in Europe for patients with deletion 17p and TP53 mutations right from the first-line treatment, and also for all other CLL patients in the relapsed setting. And for us as a clinician, it's a very important treatment, both for patients with these adverse genetic lesions, but also patients with relapses, especially if they relapse very early and the CLL has a very fast kinetic. This HELIOS trial is the second phase 2 trial, which showed us that ibrutinib is a very promising and very good agent for us to use in the treatment of CLL, that it has very good efficacy. But also it was very important that this trial could show that there's no additional toxicity if we combine it with chemoimmunotherapy.